So we were planning this since long time. Then I thought we will bring up some interesting cases so that we can discuss something. This is something you also can, if you have, I'll bring the case which I have seen or one of my friends has sent me. Some of my friends send me some cases. Those cases I'll discuss. Today's cases all are my cases only. And if you have some interesting case, you can send me if possible through Marrow. I'll see to that and we can discuss that also because we can enhance our. We shall discuss about the cases. We can discuss things and we can exchange knowledge. I'm also want to learn few things from you all because you all bringing new cases that will improve my knowledge also. So this is where we can interact and we can improve our knowledge. So today I'll be starting with stroke because stroke is one of the most common scenario and most interested scenario. So we will be discussing only cases, and then next part we will discuss further some more stroke cases. So we will start. So in next sessions we can bring up some more stroke cases. Then we will discuss some interesting cases, some scenarios, or something very practical, some guidelines, something which is practically important. So that is one way to improve your knowledge. So my aim is here I will be bringing few cases, and my aim is how we more than bringing interesting cases. It is more about learning how to approach and how to reach a diagnosis and what helped us in reaching diagnosis or what helped us making a wrong diagnosis. We can have a wrong diagnosis also, then we will correct it. It is quite practically happening sometimes. Before starting with the stroke, you should know basic things about your MRI. So MRI, when you see a MRI, which is important for stroke, you have T1 weight image, T2 weight, flare, diffusion, ADC, and SWE. These are the 6 image sequence you should know for the purpose of understanding stroke. Of which you remember that only T1 and T2. T1 and T2 is enough to learn about the things. I'm not going to discuss in detail. I will just tell you in a neurologist point of view or a physician's point of view how to differentiate these images. It may not be completely scientific and all, but it will be help you to how to differentiate it. So when you look at the MRI, first you always look for two things. One is your white matter, second is your CSF. Don't look only CSF. If you look only CSF, you will confuse. I'll tell you how you will get confused. So you just remember that you want to know only these two things. Your T1 and T2. That is only two things you need to understand. So T1, it is the first image taken, and where you will have the white matter will have the normal anatomical consistency. That means white matter is white in color. So you see here the first one, you can see this is a white matter. This is white matter is white in color. You see the white matter is white in color. So here you see the CSF is dark in color. So CSF dark and white matter white, normal anatomy is maintained. That is T1 weight image. So T1 weight image means white matter is white, dark, CSF is dark. Then below image, you see that white matter is dark and CSF is white. So this is T2 based image. Okay. So CSF and white matter are the two things you should see. If CSF is dark and white matter is white, that is T1. If CSF is white and white matter is dark, that is T2. Clear? So that is the T1 and T2. Then you should know what is flare. So you see remaining all those things, flare, DW, diffusion, ADC, SW, all these are actually modifications of T2. Basically, T1 and T2 are the basic images. Remaining things are actually modification of T2 image. So it will carry some of the properties of T2. It will carry some of the properties of T2. So T1, white matter is white, CSF is dark. T2, white matter will be darker, CSF will be white. Okay. So now we'll go to what is flare. So you see here on your this one, that is actually a CSF is white in color, white matter is dark in color, so it is T2. Clear? What about the next one? Here the CSF is dark, but see the white matter, that is also dark. So both are dark. CSF as well as white matter, both are dark. That is known as flare. This fluid attenuated inversion recovery sequence. That is, a fluid is attenuated by using some modalities, and that is what is known as flare. So T1, white matter is white, CSF is dark. T2, white matter is dark and CSF is white. Flare is both are dark. CSF flare is somewhere just a T2 with the CSF is dark. That is flare. So you will get confused between when you see these two images. So what do you see on this one? First one, here you see the CSF. CSF is dark. Here also CSF is dark. You may have a tendency to label the both as T1 or if you have no idea about the white matter. See the white matter is white in color. So white matter white, CSF dark, that is T1. Here you see the white matter is dark. Both are dark. It actually carries the quality of T2 plus fluid is attenuated. So that is flare. So if you study only CSF, the confusion happens just because the both T1 and flare will get confused if you not look at the white matter. Okay. Another easy way to remember is T2 water white. You have two W's, water white. So T2 has both water is white, CSF is white. But if you study that only, you will get confused more. So this method is just remember this. T1 white matter is white, normal anatomy is maintained, CSF is dark. T2 white matter is dark, CSF is white. Flare is a fluid is inverted in T2, so it carries a property of T2. Only that CSF is dark. So ultimately, both white matter and CSF both are dark. So you understood T1, you understood diffusion. I mean flare. Now we'll go to next image. What are you seeing here? Are the upper two are actually diffusion wave images. Diffusion wave images. This one is ADC and this one is SW image. These are the image, especially diffusion wave image is very, very important for stroke because this is where you will find the first changes. Initial changes will happen in the diffusion. It happens even within half an hour. But the changes happens in flare a little bit later. So you see the diffusion, it looks almost like a flare only. You can see the CSF is dark and white matter also is dark. It almost looks like flare only. So again, next confusion happened. The first confusion was between T1 versus flare. That was the first confusion. We solved it by using the white matter. Here, the next confusion here comes is a diffusion rate images versus flare. How will you solve it is, in diffusion, if you see this is a flare image. If you see the anatomy is well maintained, you can see very clarity of the gyre and sulci, and you can see the skull here. But you come here, you can remember like 3 points. This is actually very practical points. It may not be scientific. This is a way I used to remember when I was a PG student. Like one thing is diffusion, the clarity of the image is much lesser than flare. Second thing, skull may not be that much well seen. Third thing is you look at the orbit. The content of the orbit or the sinus is not properly visualized in diffusion as well as all these three images, diffusion or ADC or SW. Otherwise, you may get confused in the exam. They keep a question about DW flare. So that is how you differentiate. That is an easy way to pick up DW. So first thing is it looks like flare, but the clarity is much lesser. Second is you may not see the cranial and extra outside brain structures are not clearly seen. And you may not see the skull also. That are 3 points you can differentiate DW versus flare. So that was diffusion. Diffusion changes will happen first. So whatever you see in white is known as hyperindex. So then come to the below image, that is ADC. ADC is actually an extra plotted mapping of something. I'm not going to discuss that. That we will discuss when you're discussing neuroradiology. So in ADC, the important point in stroke is if there is a diffusion, there is a white color, there is hyperintensity. If that happens to be darker, that forms dark color in ADC, then it is an acute infarct. If the white color in the diffusion is not dark in the ADC, that is not acute, that is chronic. That is the only thing you should remember from ADC using ADC. ADC used to pick acute infarcts. Actually, it is not acute infarct. It is actually the cytotoxic edemas that is picked up in diffusion. I'm not going to the pathology and details. Just remember this thing. So you had studied about T1 image, T2 image, flare, diffusion, ADC, and SW. SW I'll tell later. So diffusion is just looks like flare, but the clarity is less. The skull is not seen, the eyes are not seen. Diffusion is something which is used to pick the early stroke. ADC, if it is acute cytotoxic edema or acute stroke, ADC will show dark color in the corresponding area where the diffusion shows hyperintensity. The white color in diffusion will shows dark color in ADC. Then what is the last image? That is SW. SW or GRE. These are sequences, gradient related sequence. These are sequences used to measure the bleed, see the bleed. So whenever you see an image which looks like very much like T2, but again the clarity is very poor, and you don't see that much clear sulci, gyre, and all those things. Again, the eyeball, the other structures are not well seen. This is actually a gray brain plus black blood. This is one thing you can remember. Like blood, thrombus, or even arteries having the blood that will looks black. Even the calcium may looks black. hemosiderin or iron containing substance looks black color in SW. So SW is used to pick bleed. So for a stroke protocol, you need to have just a flare, diffusion, ADC, and SW. You can pick most of things. Diffusion will pick the first changes in a stroke. Later, it will appear on the flare. And if diffusion hyperintensity is showing dark color on ADC, that means acute infarct. If it is not dark, it is not acute infarct. It may be a chronic infarct. And in SW, if it is a gray color, there is a brain. With a black color is a blood. So if there is a confusion between a bleeding or infarct, you can look at the SW. If again you have confusion, the best modality is always CT. You can take a CT correlate to see whether there is bleed or not. So I hope that you all are well familiarized with this thing now. T1, remember, white matter is white, CSF is dark. Normal anatomy of white matter is well maintained. While T2 is water white, CSF is white, but white matter is dark. Remember the white matter, otherwise you will get confused. Flare is a modification of T2 where the fluid is subtracted, or the CSF also become dark. Both are dark in flare. Diffusion looks like flare, but they are different, I told. ADC is used to pick acute infarct. SW is used to pick bleed. This much is enough for understanding stroke. I'm not going to details of what all things are there and all. So with that in mind, this is something which I have discussed in our class. This is the aspect score. This is something which you used to pick, like, just remember, I'm not going to details of this. This we will discuss when we are discussing the images of stroke in some day. So this is actually, if the aspect score is less than 6, that is not absolute contraindication, but the prognosis is poor. There is a high chance that it can bleed if you lyse or intervene the patient. So that is basically, it calculates only MCA, no other vessels are covered. I'm not going to details of that. So these are the indications which you all might know. Now, window is 4.5 hours the window for lysis. These are the contraindications. There are 17 contraindications. Some of them are actually not absolute. You can or depending on situation, you can take it. So I'm not going to discuss all those things because they're Pakka theory. So this is how altiplase is given, 0.9 milligram per kg, 10% dose of IV bolus and remaining as over 1 hour. So we'll go to the first case. So this is the first case. A 46-year-old male, diabetic and smoker. Remember that, diabetic and smoker. Presented at 2:30 p.m. So entered to casualty. This is our own case. It entered to casualty at 2:30 p.m. with acute onset of weakness of left upper limb and lower limb since 11 a.m. So he has a weakness since 11 a.m. Now the window is around 3.5 hours. That is a window. He came to casualty. So whether there is any doubt that it is stroke or not, there is no doubt because it is hyperacute onset, unilateral weakness, it is stroke. On examination, he was conscious. BP was 190 by 110. Severe dysarthria, eye deviation to right side, left human facial palsy, left upper limb grade 2, lower limb grade 4. How you localize it? And what is the importance of this localization? That also I tell. Severe dysarthria. So dysarthria means it has less localizing value. Dysarthria you can have dysarthria in a brainstem stroke. You can have dysarthria in cerebellar stroke. You can have dysarthria in cortical or subcortical stroke. So it doesn't have any localization value, but you can definitely tell that once dysarthria is there, the lesion is above cervical spinal cord. Because spinal ischemia also comes under acute stroke. Clear? So whenever there is a dysarthria, that you localize each symptoms. So dysarthria is there, that means it should be above spinal. That is the only thing you can tell, not much localization of dysarthria. And eye deviation to right side. Eye deviation to right side is a very much good hint. That means that you have two centers which control the eye movement. One is your cortical, second is your sixth nerve nucleus, that is horizontal gaze is controlled sixth nerve nucleus that lies in the pons. So one in the brainstem, one in the cortex. Just remember the cortex. Just look into my video, not in the slide. I will tell you how it is. So whenever you have a stroke on my right side, suppose my right side is going to have a stroke, right MC, the eye will deviate to same side. Actually, the eye is deviating to right side. That telling that here is the problem, here is the problem. Just remember that. Here is a problem, here is a problem. That means whenever your eye is deviated to right side, in a cortical problem, that tells you that the right MC is damaged. Because the frontal lobe contains eye movement control area. This frontal lobe is supplied by MC. This patient has a deviation of eye to right side. That tells that either right MCA is gone, or if it is, I told that there are two centers. One center is at the cortex, second center is at the brainstem, that is at somewhere in the pons. So you are, suppose look at the video again, not into the slide. Suppose I am having a difficulty to look at my right side, or this right side I am not able to look.
So my eye movement to right side, the command comes to the left side of the brain. It goes down, crosses at pons, goes to my right side sixth nerve, and then lateral rectus act, and I will move towards right side. Clear? Left cortex to right, a lateral rectus nucleus goes to lateral rectus. So if it is a pontine lesion, it causes deviation of eye to the same side. Is like you cannot move the eye to right side. I will be deviated to opposite side. If my right pontine damage, I cannot move to right side because right your lateral rectus nerve was moving the eye towards right side. So I will deviate to left side. So just study the first thing. Just study the MCA. Just remember that the other thing, the brainstem structure, exactly opposite thing happened. Just remember this thing. Whenever your eye deviate to right side, that tells I am telling you that I is telling you that here is a lesion. Look here, look here. That is what I is communicating you. The way you remember that, that is a cortical icon. Exactly opposite thing happens when you have a brainstem lesion. So this tells that either right MCA or a pontine, both is possible. Right MCA or left pontine, both is possible because dysarthria is in localization. So from dysarthria, you told that it is somewhere above cervical spine. From eye deviation right side, it can be either right MCA territory or a left pontine. Next symptom, next finding is left UMN facial. So your motor nucleus of facial nerve is located at the level of pons. So if the lesion happens above pons, UMN facial palsy will happen. Below pons, no facial palsy. At pons, LMN facial palsy. So this is giving a hint that this is above pons, and that is on the left side. So that tells you that the lesion should be most likely to be right MCA. From this, I am sure that the lesion is in the right MCA. Any more hint available in the history? One more hint. You see the grade 2 power in the upper limb and grade 4 in the lower limb. That means that upper limb is more weaker than lower limb. So what does that imply? You know that you have motor homunculus. The motor homunculus maximum representation happens to the face and upper limb, particularly thumb. So whenever there is a motor cortex is involved, you will have a significant weakness of the face and hand. Faciobrachial dominance can occur in a motor cortex involved. So this also telling me that it is more likely, it's not always, more likely to be a cortical lesion. This also gives me idea that it is a cortical lesion. So my diagnosis from the history is a right MCA. Why I am more worried about it is whenever I am having a cortical dense sign like this, I am looking at a patient who might have a large vessel occlusion because you are having cortical signs. If it was left side infarct is easy, you will get aphasia. Right side, you won't get aphasia. So that is something which from the history you are localized into most likely localization is right MCA territory stroke. Then GRBS is 123. NIHS score is a score which we calculate for decision making of lysis. But remember, NIHS score is useful only for MCA territory. It is not that useful for posterior circulation. Posterior circulation, it may not be that much beneficial. So NIHS score is 11. So NIHS score also, if it is more than 7, it tells that it is most like within 3 hours the patient comes to you and NIHS score is more than 7, 84% positive predictive value that it is a large. If it is more than 10, it is definitely, it is most likely to be large. That also tells you that it is a large location. So whenever a patient comes to casualty with stroke, your idea is to have a vascular imaging also. It's not just to take a CT and lyse the patient. It has to, you have to understand the pathology. If it's a large vessel, you have to intervene. So always go in single setting CT plus CT angio, unless patient is a CKD. For a CT angio in acute stroke setting, you don't need to get a creatinine. You can directly go with CT angio. Only exception is patient is a non-case of CKD. Then you cannot do CT angio. Otherwise, you can go ahead with CT angio because you can save time. So we were planning for CT angio. Patient had a right left side. So we were planning for CT angio, but he had a report which from the outside hospital where he has shown which is telling that the creatinine is raised. His creatinine was 2.1. So we cannot go with CT angio. My possible diagnosis is a right MCA stroke. So I could not take an MRI because the window is very narrow, 3.5 hours. So I cannot wait for a MR angio because it'll ruin the time. Time is brain. So I went directly ahead and taken a CT. The CT was showing nothing. There is no infarct. Nothing is obviously seen. So we have lysed the patient. Our plan was to post lysis, get MR angio soon after the lysis. So we have lysed the patient and his BP was high. You look at the BP. BP was 190 by 110. Cutoff for lysing of BP is 185 110. So we have to give a labetalol injection and reduce the BP and we lyse the patient. Post lysis, there is no worsening, but the patient had no improvement. NIHS is just 10. not much improvement. So what do you do now? We went ahead with MRI with MRI. So this is MRI, and what you're seeing on the top, this is a diffusion bed image, and below is a flare. This is a diffusion bed image. Below is a flare. So you can see there is hyperintensity on this area. That is the insular area on right side. So in the motor cortex cut, I am not shown here, but there is not much infarct in that area. So that tells you that there is a clinico-radiological mismatch because the patient was having dense, significant weakness on the right side with severe dysarthria and facial, eye deviation, which in implies that frontal cortex is involved. But you don't find much infarct in the frontal area other than the insula. So what that tells you is that there is certain tissue which is not functioning, definitely not functioning. That is a time deficit. But in diffusion, these are not totally infarcted. Tissue is not gone. That means there is amount of tissue which is still live. That means which is still having electrical failure, but not cell failure. Cell failure happens once the diffusion images start coming positive. So that tells me that there is a area of brain which is salvageable. That is known as a penumbra is there. Then look at the below image, the flare. The corresponding diffusion changes are not seen in the flare. That also tells me that the infarct has not evolved. Still, the penumbra is very high. So that is how you assess your physiology. You apply your physiology into your practical scenario. So now we did an angio. You can see this is a right ICA, or no, left ICA and left MCA, and this is ACA. This is missing. The right MCA is occluded. This is the same thing which we picked up from the history. We were in doubt that this is large vessel very likely because of the high NHS score and the classical MRI, clinical findings. So we did the patient with thrombectomy, and post thrombectomy he started improving. On second day, what happened is second day patient has improved, and at discharge patient has significant dysarthria but no weakness. And after 1 month review, he had mild dysarthria and he improved. So this case I included just to understand the importance of applying physiology into your clinical practice. You apply your physiological knowledge. This is where you want to use your knowledge. When you see an MRI, you should analyze it using your logical thinking. There is a clinical radiological mismatch. There is a diffusion flare mismatch. This tells me that there is an area of cell which is not functioning because you have clinical deficit, but the patient cell is not dead. It has electrical failure. So you can salvage the tissue. That is why we are studying these things. So the patient had a fantastic improvement. This is a classical case. Nothing atypical in this, nothing interesting in it than that you understand how it works. That is the only thing I want to show you. So coming to the next case. This is actually interesting case. 82-year-old male, diabetic and hypertensive. One more thing, the last patient you see the history around circled diabetes and smoker. So patient is diabetic and smoker tells you that there is high likelihood he will have large vessel. That also is large vessel, significant background. So the next case is 82-year-old male who is diabetic and hypertensive, presented with history of weakness of his left upper limb and lower limb while getting up the bed in the early morning. So it is hyperacute. Hyperacute means vascular. So then he initially went to a nearby hospital where he underwent a CT brain, which was normal because you make it a normal image, especially in a subcortical infarct, small infarct, CT will be normal. You just see there is a bleed or not. There is no bleed, you start with antiplatelet because anyway, they had not done an MRI. A wake-up stroke, they had not done an MRI because the setting was very rural setting. They come from a faraway place. And he was admitted for 2 days. He was started dual antiplatelets and statin. And the day 2, his weakness has worsened. Because of worsening of weakness, they are referred to here. Our hospital situates near to Idiki. So this patient came all the way from Idiki. So he came on day 2. That is day 3, he came to our hospital. So on examination of casualty, he has blood pressure was 150/90. Is conscious, oriented, left upper limb grade 2 weakness, left lower limb grade 0 power. So something is atypical compared to last case. Here he has a lower limb more than upper limb weakness. That can occur. Definitely that can occur, especially in subcortical infarct. And already any diabetic patient, 82-year-old male with a left side weakness, acute onset, you will think CT is normal, you think of a subcortical infarct. So I told my JR to admit the patient and get a MRI. The MRI was shifted to MRI and MRI was done. MRI was normal. MRI is completely normal. So already third day, MRI is normal. Is it MRI negative stroke? There is an entity known as MRI negative stroke, but that is rare. Before labeling MRI negative, you should reassess the patient. that is something I have a series of cases. I will present it one day. Like I have 3, 4 cases of MRI negative. How we arrive at diagnosis, how we picked up the diagnosis, all those things we discuss. So what else? What is the possibility? So I went back and I went to the hospital and took the history of the patient. There I got something. Like when I asked the history, you look at the examination. He had only upper limb weakness and lower limb weakness. There is no dysarthria, there is no cranial nerve, no aphasia, no cortical side. Where it localizes, that is most important. See, his left upper limb, the upper limb and lower limb is involved. Upper limb means it is the lesion. Upper limb is supplied by cervical segment C5. So this can be very well be any lesion above cervical C5 because C5 is where your deltoid, that is uppermost area, deltoid and shoulder, all those supply from the C5. So any lesion above C5 can produce upper limb and lower limb weakness. It is not always in the brain. It can be in the spinal cord. So that is how important is if you keep history and localization because here this tell me that lesion is above C5 because he has weakness of left upper limb and lower limb. So I again asked the history because it is hyperacute onset. I asked him specifically whether you had any pains or something happened night. Then he told that in the night while he was sleeping in the middle of the night, he had a severe back pain around the neck. Then it subsided soon. So this clinched me to something else. So I ordered an urgent MRI neck. And so this was a MRI neck. You can see that CSF is white in there. This is T2. So you can see that how you find out the your vertebrae is you see the dents. This is this triangular thing. That is the one is C2. That is a C2 vertebra. So C2, C3, C4, 5, 6, 7. You can see that this is spinal cord. The white area is a CSF. In this area around C4, C5, C6, you don't see any CSF. You can see a black color thing, a heterogeneous. There are some hyperintensities within and some hypointensity thing is there. So that is compressing it. So again, this is a T2. This is clear now. Now we will go to the next image. That is here. This is T. Water is white. That is T2. Here you can see CSF is dark. This is T1 image. This one is T1 image. So here in T1 also you can see it is almost isodense, almost same intensity to spinal cord. But there are some hyperintensities within. You can see some white color within. So what is it? Again, go back to the history. It is a hyperacute thing and it started with neck pain. So if it is hyperacute, the diagnosis is always vascular. So if you think of a vascular, it may be a bleed. It can be a epidural hematoma, spinal epidural hematoma, spontaneous spinal epidural hematoma. They classically present with neck pain, but classical presentations are both upper limb and lower limb weakness. Like a hemiplegic distribution of epidural hematoma. I had searched in the internet, I could not find any cases. So we discussed with the neurosurgeon. You can see the axial view. So you can see here, this is the spine sitting here. And you can see the central area of the spinal cord. Clear? And you can see something is black, which is compressing to the other side. This is a bleed. This is a bleed, which is compressing the spinal cord there. You can see inside that black thing, there are some white spots. That is some white and black. So it was black in both T1 and T2, but there are some hyperdensities within the T1. Okay. So that is a bleed and neurosurgeon operated the case. This is something which we have published it. This you can see the hematoma here. This is the hematoma. And surgeon has removed the hematoma in the second field. And he had an improvement, but he had some deficit because this has to operate within 24 hours. Patient came to us after 3 days. But after physiotherapy and all, he's able to ambulate. He's able to move the upper limb also, but there are some weaknesses there. And this case we have published in a journal. This is our own case. We have published it in Nepal journal. So you have seen the image that I had told that it is hyper. How you calculate the age of the bleed in MRI. That is something which is interesting, which we will discuss it once in the neuroradiology session also. So, and if you have time at the end, we will discuss it there, or else in the neurology session, we will discuss it because it will take time. That is how you calculate the age of the bleed. Because I have to show 2 more cases. After the end, if we have time, we will come back and just remind me. So from the image also, we could make out that even without image, the history was a clue. Again, I want to tell you that how you apply your history, how you localize it, how you able to find out the diagnosis, even though it is a very rare presentation because epidural hematoma presenting with hemiplegia is very rare. an 82-year-old male who comes with a hemiplegia and your MRI is normal, and you localize it so that there is no dysarthria. The patient had dysarthria or any cranial nerve, I may think again of a MRI negative stroke. Brainstem stroke can have MRI negative, but the patient doesn't have those symptoms. That made me localize it to cervical spine. And again, the patient, when I asked the history, he gave the history. He had a neck pain in the back. So coming to the next case, that is a case number 3. We have 4 cases totally. The case number 3, a 54-year-old male who's CAD, coronary artery disease, on antiplatelet. He presented acute onset dizziness followed by headache and decreases. Actually, he was watering his plants in his garden. Suddenly, he felt a dizzy and a severe headache. He lied down there only. And then bystander came there and noticed that he's lying on the floor. He was moving his limbs but not responding, and he was not opening the eyes. They taken the patient directly to ER. And ER called me and told that the patient has BP of 240 by 120, pupil bilaterally small and sluggishly reacting. And they told it is altered sensorium, but moving all 4 limbs, not responding, and shifted to CT to rule out ICS because BP is very high and very fast presentation and very drastic symptoms. It is quite natural to rule out bleed. And my JR called me and told that CT done, sir, CT is normal. And I asked what is the science. He was also having the confusion because they cannot localize it. Then I went to the CT room and examined the patient once again. Then I went and examined the patient. Patient was not in complete altered sensorium. He had bilateral ptosis. Because of that, it looks like severe bilateral ptosis. Because of that, it looks like he's unable to open the eyes. And he was restless and severely dysarthric. He's not ready to communicate. And when I look at the eyes, there is a skew deviation, that is vertical malalignment. One eye is located like this, and the other eye is upward, vertical malalignment. And rightward gaze is inbuilt. This has given me the diagnosis. Because when you have a bilateral ptosis, you can have a right parietal lesion can present a bilateral mild ptosis, but this is very severe ptosis. It can occur in brainstem, it can occur in thalamus, it can occur in hypothalamus. So it favors me more likely to be a ptosis of patient. Again, it started with vertigo or dizziness. Then he is restless and severely dysarthric and skew deviation. Skew deviation happens usually in brainstem infarct or in cerebellar infarct. That is, one eye is malaligned, one eye is upward and one eye is lower. And he has a rightward gaze is impaired. I told that you have the brainstem center, there is a pons, there is a center, that is a lateral rectus nerve from the 6th nerve nucleus, which is something which helps you to look to right side. So right side of the pons should be involved with this. So that also favored me. It is a posterior circulation and there is no weakness at all. He is moving all 4 limbs, but difficult to examine the proper weakness because he is restless and not that obeying. He has some delirium. So this is a classical presentation of an entity. So I want to see one thing. This was a CT. There's a delay in the slide. Okay, this is a CT. So CT was told to be normal, but I want to look at a particular area. And my radiologist, who has done the intervention in the last case of Dr. Jayashil, he was there. And I called him and we both looked into that. There is something was there which struck me, as well as he also told that this is that only. Did you find anything in this? Anyone find anything in this image? Not MD delta. This is hyperacute thing. Hyperacute means most likely to be a infarct. See, you can see a hyperintensity here, hyperdense spot there. This is where your basilar artery comes. That is basilar dot sign. Hyperdense basilar artery, basilar dot sign, correct. So this, I looked at this not because I am seeing that. I didn't see that in the first time. When I saw the CT, I didn't see that. I could not make out that. Seriously, I could not make out that. When I went back and examined the patient, that clinched me that this will be a basilar artery stroke. This may be a top of basilar syndrome. Not MCA dot. MCA dot happens in the MCA here. That is actually, this is not actually MCA dot. This is actually calcified or the vessel flow artifact is there. This is not hyperintense. This is actually isointense. This is almost hyperintense because the presentation was bilateral ptosis with gaze abnormality and vertical skew. These tell me that it is brainstem, pakka brainstem. And the presentation is typical for a basilar artery, like something like a top of basilar syndrome, where you have the top of the basilar artery is occluded and you will have delirium or altered sensorium, severe dysarthria, and eye movement abnormality because of thalamus or the brainstem, bilateral thalamus or brainstem, multiple infarct in the area separate basilar artery, bilateral. So emergency, the window is 1.5 hours. We have shifted the patient for CT and you are there and then and there only. You can see here one vessel is going like this. That is a basilar artery. This is a basilar artery. You can see a vessel here. This is a PCA. This is a right and left PCA. You can see that this area there is no blood is there. Actual thrombus is exactly sitting there in the top of the basilar artery. So this is a top of basilar artery infarct. Because the patient presented altered sensory delirium, it could very well be labeled as something else because we could not shift the patient for MRI because patient was not stable enough to lie down on the MRI. He's very restless, irritable, is not lying even for CT, was difficult to do. And then we have planned for thrombolysis because the patient is in 1.5 window. If you calculate the NIHS score, it will be less. But NIHS doesn't count for post-circulation. This is definitely something which is life-threatening, basilar artery thrombosis. So we plan for thrombolysis, explained to the bystander, and our neurointerventions also kept ready. After lysis, we are planning like we start lysis, we shift to the cath lab and we'll do a DSA then and there only, and if needed, we'll do a thrombectomy. That is a plan. But the patient's BP was very high, 240 over 120. We had given labetalol, we had given Lasix, catheterization, multiple dose of labetalol, not improving. BP is not coming down. We started labetalol infusion and even NTG infusion I started with because it was not coming down. Time is slipping off and he developed left upper limb weakness, but BP is still high. Left upper limb, till now he doesn't have weakness. Now he had left upper limb weakness. He had rightward gaze paresis previously. That rightward gaze paresis localized to right side pons. He had left side upper limb weakness that also localizes then and there only. Then window again 1 hour pass, 2.5 hour inner pass. We cannot proceed with lysis. We don't want to waste time. So we decided directly we will go ahead with thrombectomy. We decided to stop the infusion. BP control and everything. We will shift the patient for thrombectomy to cath lab. Suddenly, patient went to cardiovascular arrest. When luckily me and my radiologist, Dr. Jason, we were both standing near, and suddenly the patient collapsed. We given CPR, put the patient back to ventilator. So now the patient BP has become stable, higher side of it, but hypotension has occurred. But the score is E1, V1, M1 on ventilator, not given any sedatives. We never give sedatives in stroke patients unless that is very much required because you cannot assess the GCs. So again, the question came whether you should go ahead. We explained the bystander because there is no doubt if you are leaving the patient is going to die. We have to take the patient. So we took our radio interventionist was very aggressive and he told that we will take the patient whatever the post, we'll explain to the bystander, we'll take the thrombectomy. We have taken the patient to cath lab without lysis, direct thrombectomy. So you see the image. The first image is the CT image which I had shown. You can see the top part basilar artery is occluded. This is a DSA image. Actually, what happens is when he put the DSA, when I given the CPR, the thrombus has migrated. So actually the basilar artery has opened. The first image you can see the top of the basilar artery is occluded. The second image you can see that after giving the CPR, because the CPR which I had given, the thrombus has automatically has been displaced. There was little bit part to aspirate. He aspirated it, and you can see the basilar artery full flow is there, but patient is on ventilator, shifted back to ICU. After 3-4 hours, he gained when he started agitating. He had started moving all 4 limbs, just trying to pull off the tube, and we extubated him. And next day morning, we took an MRI with MR angio. You can see the MR angio. These are the ICS, the tortuous vessel ICS and MCA. This is a MCA. This is a ICA. This is a ICA. And you can see the vertebral artery coming here, another vertebral artery coming here, and it forms a basilar artery. You can see the basilar artery continuing as PC. Very clearly you can see. So that it was successful and entire flow is retained. So next slide, we went forward and this is the MRI which were taken now. So in the beginning, what you have seen is patient had initially had a gaze paresis, ptosis, and later left side weakness. So it should have been the midbrain or pons. So there is nothing in the pons. This is a pons. There is nothing in the pons. Pons is totally salvaged. But there are some infarct in the cerebellum, one infarct in the thalamus. But the patient is having no weakness and patient improved like anything. He actually, this was when he came for follow-up. He was discharged with severe dysarthria and mild ataxia. After 2 months, he had mild dysarthria and ataxia. He is now on my follow-up. After 6 months, he had cerebellar signs. He had dysarthria and he had ataxia. But after now, he's almost 6-7 months since for last this event. Now he doesn't have any signs other than dysarthria and some memory loss. He has memory loss. That is because thalamic infarct. And dysarthria, maybe because thalamus plus some other cerebellum. Otherwise, he is normal. He's doing all activities. He's back to complete normal. So this is where your decision making, using the idea that if you are not interviewing now, he is going to collapse. Because there are multiple issues. Initially, diagnosis was confusion. Because the history has pointed me to look into that basilar artery. And my interventionist was so good that he was there ready to see the MRI and taken the patient for intervention. And when we tried forward with lysis, we could not lyse the patient. So we decided we don't have to waste the time, even though window is still 4.5 hours, you are just 2.5 hours from the onset. Still, we think that if time we waste, the brainstem is gonna damage. If brainstem is damaged, gone. You cannot intervene, nothing. He will bleed. So we decided we directly take the patient. Then suddenly the patient got arrested. We intubated, post-intubation, the GCS was very bad. Then somebody will think, with that bad GCS, why are you taking for thrombectomy? No, because you know the pathology is in the basilar artery. If you're not entering, patient is going to die. So you have no other choice left. You have to go ahead with the procedure because window is also very early. And luckily for the patient survived. So that case gives you the idea that all these cases gives you the idea that how you correlate your history with your examination, with your image, and with the pathophysiology. How will you bring your physiology into? This is a really interesting case. This is the last case. A 62-year-old male, history of fever and chills since afternoon. He was very fine till the afternoon. He had history of fever or chills in the afternoon, and he was not feeling well. By 5 o'clock, he came back and he went to the bed and slept. Then, by around 7 p.m., the bystander noticed that he is lying on the bed, was looking confused, unable to speak, or to unable to comprehend. He is not talking. He's like aphasic, and he's a diabetic, CAD on regular treatment, and his onset, he went to sleep by 5 p.m. and bystander noticed at 7 p.m. They came to casualty at 7:30 p.m. So from the last seen normal, this is a wake-up stroke, but from the last seen normal time is 2.5 hours. There is no need of MRI here also, because you can go ahead with the lysis if you have clinical diagnosis of stroke. And on examination, he was mute, restless. On pain, there is a reduced movement of right side. We cannot assess the exact power and all because he is not obeying the commands. And he is looking at you with the complete consciousness, but he is not obeying commands. He is totally confused. He is totally mute. So we have a clinical diagnosis of stroke, and he is very restless. We cannot take him to the MRI room. He is not stable. For the otherwise, you have to sedate, you ventilate, and take him for MRI. There is no need for that because your diagnosis is clear. You have a right side weakness that localized to left side of the brain, and you have an aphasia that localized to left MCA. So left MCA having right side weakness, aphasia, there is nothing else to do. So we took a CT plus CT angio, was normal, and patient was lysed with the altiplace. After 15-20 minutes, patient started moving his right side, started talking, but he was totally disoriented. He started agitating. He started to get up and run away. We had to restrain him. This is something which we never see in stroke, because patient is usually in stroke when they lyse, the patient improves. The patient is going to delirium. I was totally confused. I got from a call from the my ICU that he is very agitated. Then I thought he may be alcoholic or he had fever, some delirium may be there. On the next day, he was febrile. He was confused, but he has some word finding errors, but he was able to communicate. He was no deficit other than that. And he told that he doesn't remember what happened the night. He remember till he went to sleep, and then when he woke up, what he remember is in the morning. He doesn't remember anything. And MRI was repeated on next day, which was no infarct. Then I went, this is an angiogram. This is a reconstructed angiogram. You can see that two vertebral artery coming and joining before the basilar artery, and the PCS are there, the MCS are there. Everything is well and fine. When I went, this is an MRI. I went and talked with my neuro radiologist. Again, sir is very good to communicate. So we went and talked with him, and he told that there is something he find obvious in this MRI. Did you find anything in this MRI? Anyone find anything in this MRI? I'll show one more MRI. This is actually white matter is dark, CSF is dark, and skull is not seen. This is actually a diffusion, and this is an SW image. This one is just much clear. Anyone notice anything? Can you see here in the posterior horn there is something is there? On the left posterior horn there is something sitting here. So there is a clear fluid level like thing there. You can see here also clear fluid like thing. Here also you can see that clear fluid like thing. So that is a debris which is located in that area. This is classically seen in ventriculitis. This is classically seen in ventriculitis. The patient doesn't have any neck stiffness also. He had only 1 day history of fever. This is classical ventriculitis. It is not hemorrhagic, because if it is hemorrhagic, SW will show black color. SW is not black. So it is just means that it is a cellular debris. It is hyperindex. Actually, T1 also it is hyperindex. That means high protein content. T1 when it is white, you have only few diagnoses. T1 it is white, certain stages of bleed, fat, manganese, and high protein content. These are the 4 things where you will get white color in T1. Remaining everything pathology is black in T1. Fat, manganese, certain stages of bleed, and high proteinaceous fluid. So T1 also actually I forgot to put the T1. It was actually hypertense. So the diagnosis is ventriculitis, but we have lyse patient. So this tells that even if what I want to communicate is even if patient comes with a stroke mimic, if you have a clinical diagnosis of stroke, you can lyse the patient. Because if it happens out to be stroke later, you don't have any time left. The stroke mimic, if there is no contraindication, clinically it is stroke, you can lyse. So stroke diagnosis is clinical, not MRI is not always must. And MRI is needed if you have diagnostic confusion. This patient, we don't have much diagnostic confusion because he has aphasic and there was some position on the right side. After lysis, it improved. Then we reassess a CT. It was a repeat CT, it was not initial CT. The repeat CT we just done when the patient is agitated. I had studied the patient, taken a repeat CT to see whether there's a bleed happened. So here also you can see the hypertensity in the posture of there also it was there. It was very subtle in the CT. It was very difficult to find out because unless you have the history. And I didn't think about that. The thing which picked was, for me, it was the patient was telling he was not able to remember what happened and he had fever. So I think that that thing usually doesn't happen in stroke. And third thing is he had delirium. That is almost like a post-ictal stage. So he might had went to the bed and had a seizure. And post-ictal phase, he might have weakness also. You can see the ventriculitis is dominant on the left side also. So it might have resulted in a left-sided onset seizure. And that might have resulted in his deficit. Or it may be a vasculitis secondary to infection. So we went ahead with CSF. CSF was shown 920 cells, 80% neutrophils. I did a EEG, which shows diffuse theta slowing. That also is uncommon to occur. Actually, I did EEG prior to taking the MRI because I had a doubt in the morning when I took the rounds whether it is an encephalitis or something. I took an EEG, EEG was showing. Then I discussed with my radiologist whether there is something we are looking into this area, what is that and that. Then we started him on ceftriaxone ampicillin. Culture was positive streptococcus pneumoniae. And we given 14 days of ceftriaxone and fever subsided. And at the repeat, we did a CT, MRI screening, which showed complete clearance, as well as we did a CSF also. It was complete clearance of CSF also. So this was something which is a stroke mimic. So what I want to convey is, again, many things will be labeled as stroke. But if you have a clinical diagnosis of stroke, there is no problem. You can go ahead with lysis. If a clinical diagnosis, pakka sure. If you have doubt, you go ahead with MRI. Otherwise, you can go with CT, and just a minimal investigation. It should be done. And take the patient for the lysis at the earliest. Don't waste time for any other investigation or any other control, anything. If you, like the third case where you have a basilar thrombus, if I have waited for the patient BP to control and waited for 4.5 hours, at that time the brainstem might have been gone because he started developing weakness. That tells me that just progress to the brainstem is worsening if you're taking now or never. So that was about the 4 cases. And one thing we will discuss about, I have kept it aside, the bleeding in MRI. So this is one mnemonic which I will tell you to remember. That this is something which I used to know. This helped me to remember every time. I bleed, I die, bleed, die, bleed, die, die. It looks very funny. It looks difficult, but to studying the concept otherwise is more difficult for. So you have a hyperacute stroke, acute stroke, early subacute, late subacute, chronic. Hyperacute is within 1 day, acute is within 1 to 3 days, early subacute is up to 1 week, late subacute is up to 28 days, 14 to 28 days, almost 1 month. Chronic is more than 1 month. So T1, I bleed means T1 is iso and T2 is bright. So T1 is iso to spinal cord and T2 is bright is acute. In hyperacute. Acute means T1 is iso, T2 is dark. So look at our image. This is the T1. T1 it is dark with some hyperintensities. T2 also is dark. So it means both are dark. Iso intense and dark. That is acute. It is almost 1 to 3 days. That was actually the age of the bleed. And early subacute, T1 it will be bright, that is white in color. T2 it will be dark in color. Late subacute, T1 bright, T2 bright, and chronic, T1 dark, T2 dark. Both are dark in late. ISO means same intensity with the gray matter. So this is difficult to remember. This is the only thing I found to remember is using this mnemonic, which I got from internet, not my own creation. This is something which I got from internet. So this is something which I used to remember the bleed. Otherwise, in MRI, otherwise it's very difficult for me to remember. There is a lot of pathogenesis, deoxygenated hemoglobin, hemocyte, and all those things. You can study that, but the most important thing is not to waste your brain for unnecessary things. You just want to know whether that is acute or hyperacute practically. So just keep the things what you needed. Otherwise, your brain will be overloaded. So this was about the cases, and we shall continue this discussion. And we have plenty of variety of cases. Like we have actually, I had some 10, 12 cases of stroke I had taken, but I thought that I will take only 4 cases today. Remaining will later discuss later. So any queries, any doubt? Flare versus ADC. Actually, I will show once again. So you see here, uh, this is a flare image. Okay, flare image, the CSF is dark. See, here it is, CSF is bright. Okay, so SWA, when ADC also actually CSF is bright. It looks like ADC is actually absolute diffusion coefficient. This is actually you use to find out the diffusivity of hydrogen. The flare and diffusion, diffusion and ADC both work on this principle. The hydrogen molecule, whether it is diffusing or not. The hydrogen molecules are located inside your cell, and when cytotoxic edema happen, it cannot move out. So it will get trapped. Then it will show hyperintense, white color and diffusion. But diffusion is a modification of flare. So whatever white in the flare will show white in the diffusion. If it is old also, old infarct also will be white in diffusion and can be white in flare also. So when it is acute, how to differentiate is that we calculate the absolute diffusion coefficient. That is a physics use a calculation, and we will extrapolate that calculated value as a mapping into the T2 image, so that we will make a ADC image. So ADC looks like T2, but it is much more darker. You won't see the skull base, you won't see the eyeballs, you won't see the skull, you won't see the better anatomy is not visualized. Just a small image which just gives an impression of absolute diffusion coefficient. That is ADC. So next question was enoxaparin LMW. This thing everyone has asked. So per se, there is no evidence of using LMWH or unfractured heparin in stroke, except in cardioembolic stroke. Cardioembolic stroke, you can start, that we have discussed in our module. We can start it, depends upon certain situations. But otherwise, this doesn't have any role. Even for DVT prophylaxis, pneumatic compression is preferred more than enoxaparin. But in practical scenario, enoxaparin is given for DVT prophylaxis. But there has been many studies. There has been many studies which has shown that they have some benefit in those with mobile thrombus. So practically, where other condition where we use is when you have a ICA thrombus which is mobile, then you can give heparin. Or sometimes the patient has on dual antiplatelet getting recurrent stroke, we may give heparin. Otherwise, there is no definite evidence of heparin. Then about anti-epileptic in ICH, there is no prophylactic use of anti-epileptic per se, other than SAH or penetrating trauma. Otherwise, if seizure there, you can start. But many used to start as prophylactic. There is no prophylactic evidence there straight away. But neurosurgeons used to, their guidelines used to put anti-epileptics for ICH, but we don't put. What else was the question? Dual antiplatelet. Dual antiplatelets are indicated in those with ICAD, intracranial atherosclerotic disease, more than 50% occlusion of intracranial vessels. You can give dual antiplatelets for 3 months. In TIA, you can give dual antiplatelets for 3 weeks, TIA and minor stroke. More than 3 months, no definite evidence, unless patient has other indications, like recurrent stroke on single or a cardiac indication, you can. Otherwise, single is enough. Skew deviation is basically, skew deviation means vertical malalignment. Vertical malalignment because vertical control is maintained by rostral MLF, RIMLF plus certain cerebellar area. So brainstem and cerebellum is involved in the vertical alignment or the eye alignment. So it means that it is predominantly from either cerebellum or from the sometimes in the peripheral tract also it can happen. Steroids has absolutely no role in stroke unless it is a vasculitis. Vasculitis is only indication of steroids. Demyelination cannot have a hyperacute symptom. Demyelination present with acute. Hyperacute means patient is telling that I am sitting and writing my notes. Suddenly at 9:30 I had a weakness right up. That is hyperacute. But if the patient is telling that morning I had some problem, by evening I had weakness, next day I have weakness of lower limb, that is classical history of demyelination. That is not acute. That is not hyperacute. It's acute. Management of CSVT is again LMWH. You can give LMWH or heparin depending upon, later you convert to anticoagulation. Depending upon the etiology, you have to decide whether you have to continue it or not. minimal 6 to 12 months you can give. Then you decide on the etiology. If it is etiology is not correctable, you may have to continue lifelong. Faciobrachial weakness in case number 1 is if you have motor homunculus is there. The motor homunculus, the representation of face arm is much more. If you take the homunculus picture from your net, it is much larger than your uh, leg. So whenever you have a cortical weakness, it is a predominance of involvement of the face and upper limb is very common. That is known as faciobrachial point is much higher when you have a cortical weakness. Role of mannitol. Mannitol has a role only if there is a large infarct causing the edema. Mannitol is primarily given to reduce edema. The edema happens whenever the patient has stroke. The edema occurs maximum 3 to 5 days. By 5th day onwards, edema comes down. And once a 10-day course, edema disappears. So you can give up to 1 week. After that, depends upon the size of the stroke, you can taper down and stop. You don't need to continue full dose. You cannot stop it all away also. When to start anticoagulation stroke there, we have discussed the module. There is a particular guidelines. He said it is not a guidelines. It is actually came in American Pharmacology Journal. You divide into 3, 6, and 12. If a patient comes to you with a TIA, you can start on day 1. If it is a minor stroke, you start on day 3. If the NIHS is more than 8 to 16, you start on day 6. If it is more than 16, you start on day 12. 3, 6, and 12, you repeat a CT. If CT doesn't show bleed, you can start dual anticoagulation. That is anticoagulation in AF. High dose statin in stroke, high dose statin definitely has to be given. It has multiple other properties because one, it decreases inflammation. Second, it causes plaque stabilization. Third, it causes decrease in platelet aggregation to plate. So all the plus rapid reduction in LDL. These things you need to attain with high dose of statin. Window there is no harm in giving loading dose, but if you are giving heparin or clexane, you cannot load thrombolase. But other drugs you can. So when there was start hypertension in hypertension patient. That is actually like when the patient is already on a treatment. There is no guidelines per se. There are practical points I'll tell you. Like the patient is already on a antihypertensive and the BP is still high, you can restart that. But think that if the patient is having a large vessel stroke, suppose the patient is having an IC occlusion, you cannot go ahead with reduce BP high. Very low reduction of BP is harmful. Sometimes in patient with significant critical stenosis with TIA, we used to keep high BP. We used to give noradrenaline to maintain BP at 130 to 160 and all. Because you need to have perfusion. Later, slowly after 3 or 4 days, you will slowly taper it and reduce it. Because you need to perfuse also. So according to the scenario, you can manage. Again, one thing which can help you is your perfusion image. If you have an ASL perfusion or you have a spin level perfusion or some perfusion, you can plan it better. So these all things basically you have to think of the physiology and decide. Mannitol versus 3% versus cerebral edema, which is preferred and why? Actually, mannitol is better because 3% is actually not equivalent to mannitol. There is a refractory index. There's an index which is used for to calculate how effective is your osmolar agent. That index, if you take, almost mannitol equivalents will come around. I remember is somewhere around 17 to 23% of NaCl. So actually NaCl has lesser amount, but NaCl is effective whenever the patient is having CKD or CAD. You cannot give mannitol. Such scenario we used to do 3%. Otherwise you go with mannitol. But practically when it's a large, in fact we give both. Steroid or elastics and role in reducing edema. Steroid practically actually guidelines tells steroids is better to avoid. But steroid basically you should understand the pathophysiology of this edema. Here the edema is because of cytotoxic edema. Cell is lack of oxygen and cell swells up because of cytotoxic edema. So cytotoxic edema, steroid doesn't work. Cytotoxic edema is managed by mannitol. But if you have an ventriculitis like our case or encephalitis where you have vasogenic edema because of inflammation, the vessel is inflamed and leaky, there steroid works. But sometimes in a large infarct, you don't have anything to give. I have also given sometimes because you don't have anything to give and patient party is not willing for craniotomy. You don't have anything to give. Then we can offer it because there is no harm in it. Sometimes you have to take such decisions. Indication of CT angio and MR angio. MR angio is always inferior to CT angio. If available and possible, CT angio is always best. If you cannot do CT angio or if LFT, RFT is rearranged, go with MR. Dose of aspirin, actually there is no specific dose. Different guidelines for different doses. 75 to actually 80 to 320 is recommended. So we used to give 150. Right side hemiparesis. Right side hemiparesis is because of the he had an aphasia. Last case he had an aphasia, and he had a ventriculitis which was dominant on the left side. So he might, that is my assumption, he might have two possibilities I can keep. One is he might had a seizure. That is why he was lying in the bed. Nobody has seen what happened during that day. That is why he was confused. He was restless, irritable, and post-ictal phase was there, and he doesn't remember the event. So he went with seizure. And left side organ seizure, you will have post-ictal phase, you will have left-sided dysfunction. So we will have right hemiparesis and aphasia. It's not dense hemiplegia. He has positive movement on right side. It is not dense hemiplegia. He was moving the limb, but we could not exactly document the grade of power because he is not obeying command. But on pain, he was moving, but right side was slight positive. Role of dual antiplatelets in lacunar infarct. If it doesn't have any particular role in lacunar infarct, if it's a minor stroke, you can give. Again, you don't know exactly the pathogenesis of how the pathogenesis of lacunar infarct happens and how effective is your antiplatelets or available therapies are. So that is one area of debate. Now there are guidelines to use ticagrelor. There are guidelines to use. I mean, some of the studies and guidelines are coming up, not in American, to use tirofiban infusion in those with lacunar infarct. But guidelines it is not recommended. If imaging is not available in a remote area less than 1 hour, okay. If your patient comes to stroke, if you don't have imaging, you cannot do anything. Refer the patient at the earliest because you cannot load antiplatelet. You don't know whether it is bleed or not. Refer the patient at the earliest. Even if they reach by 1 hour or 2 hours, do no harm. That is the most important thing in our practice. You should not do harm. You are not sure, you don't have evidence, don't give. Shift the patient to a center where you have at least a CT. If CT is normal, you can lyse. No need for angio, no need for anything. If CT is normal, clinical diagnosis, lyse. Always take the clinical window. How to differentiate cortical versus brainstem stroke. This has been discussed multiple times. Like in module, it is there in detail. So cortical stroke will have cortical findings, aphasia, praxia, all those things will be there. While subcortical brainstem stroke will have crossed hemiplegias, right side cranial nerve, in one side cranial nerve, ipsilateral cranial nerve, and opposite side weakness. When to restart antiplatelet after ICH? That is an interesting question. Like if you have an ICH, you have to repeat CT, and when the bleed has resolved, you can start. You can repeat CT ideally by 2 weeks. 2 weeks you take a repeat CT, and if the bleed is resolving, you can start. Or if the patient is already having severe valvular disease, severe vascular disease like POVD or recent MI, recent stroke, you need to start it early. Such conditions, if the stroke start resolving and after 2 weeks, you can slowly reintroduce because consider the risk benefit. Role of anticoagulation, hemorrhagic transformation of infarct. Hemorrhagic transformation of infarct, actually, you divide it. There is a study, ICAS 2 or 3, I just don't remember, where we classify the hemorrhagic infarct to HI1, HI2, PH1, PH2. HI1 means hemorrhagic infarct 1. HI2 means hemorrhagic infarct 2. HI1 means if the petechial hemorrhage, the dots of hemorrhages are there, and that is less than 30% of the total infarct, less than 1/3 of the total infarct, then you will call it as HI1. HI1, there is no absolute contraindication for anticoagulation or antiplatelet. Then HI2, there is no absolute contraindication, but better to avoid dual and better to avoid anticoagulation. That means petechial hemorrhages are there, that is more than 30% or more than 1/3 of the infarct. And if it is PH, parenchymal hemorrhage, you cannot give anticoagulation, you cannot give antiplatelet. Where you have a frank bleed, you cannot. Microbleeds is never a contraindication for lysis also, but you have to again decide on patient to patient. Suppose I am seeing a patient who has so many multiple microbleeds and he is having cortical superficial and I am thinking of an amyloid, you better not to give dual antiplatelets, better not to give lysis. With ITP, we can give antiplatelets. ITP depends upon, like, you can give single antiplatelet if the platelet functions are normal. The one thing is, this is not guidelines. This is practically something you can do is, if the platelet functions are normal and platelet count is more than 50,000, they can give single antiplatelets. If more than 1 lakh, you can give both antiplatelets. Dual antiplatelet duration, TIA and post-stroke. If it is thrombectomy, especially when you have stented the patient, you need to give dual antiplatelets for long time. Maybe 3 months, 1 year, exact guidelines are not there because it's evolving. Right now, we are giving for 1 month, 1 year. Then depends upon patient to patient. Patient has other comorbidities, recurrent history, we will continue dual with stent. Without stent, you can give maximum for 90 days is recommended for large vessels, and minor stroke and TAA 3 months. That is based on 2 trials. One is stance and point trial for TAA, and Sambris trial for ICATS. Any questions I missed? Not able to see the questions. There's a lot of questions. Dawn and diffuse trial. That is a huge trial. Like just I will tell the nutshell. Dawn and diffuse trials are actually done for extended thrombectomy, like extended window after 6 hours. Just remember diffuse, the name is diffuse. It used perfusion. It used perfusion study. While Dawn used clinical radiological mismatch, just like our first case, where I had told clinical radiological mismatch. There's a significant weakness, infarct is small. So that is using Dawn. We uses Dawn because we don't have perfusion. So it depends upon the case to case and center to center. You can use either of the criteria. So that is a Dawn and diffuse. Dawn and diffuse both are late window lysis, late window thrombectomy, not lysis. Dawn uses clinical radiological mismatch, diffuse perfusion scan. MRI neck is mandatory for all cases. MRI negative stroke, no. Like MRI negative stroke, such an entity is, I feel it is more of a funny entity. Like sometimes this may not be stroke. You have that, like in our second case, I mean that bleed. So you have to clinically sure that it is it's a typical stroke. Second thing is MRI negative stroke. I had a series of cases. I will discuss that in the later coming week. You have to clinically localize and then look at the MRI. You have to take a certain protocols in MRI and to look for that. Then you may find it. And MRI neck is not always mandatory because neck you can screen with ultrasound. So if you have cost effectiveness, you can go with ultrasound. If you have, because neck will take again time, like you are wasting the window. But if your patient is not in window period, then you have the liberty. You can do an MRI. Better is good for CT angio because CT angio is a better imaging and DSA is a best imaging. But DSA again is cost constraints, the procedure. So CT is better than doing an MRI. And if you cannot do CT, you can definitely go with MRI neck. But we used to follow is neck ultrasound, Doppler, and MRI. Mannitol given for how many days? I had told it that you have to give for 3 to 5 days is a maximum period where you have the maximum edema, third day to fifth day. Once it crosses the fifth day, edema comes down. So you should give a higher dose till fifth or sixth day. Then you slowly start reducing depending upon image as well as clinical finding, and slowly you will stop it later. Second patient thrombolysis. No, second patient was not thrombolysis. Second patient actually came on day 3. It was lucky that he didn't come on the first day because if you taken CT, you might have lysed it. So this is something which is very rare because I had never found in literature an epidural hematoma present unilaterally. I had seen 3 epidural hematomas spontaneous. The third one. First was when I was doing my DM. And second was when I joined in my college, my present working place, MOSC. So both cases presented with quadriparesis. And they had significant back pain, typical symptom. But this patient is totally weird. This is the first case. That is why we reported it also. As much as my knowledge, so which agent is more beneficial, altiplase versus tenalteplase? This is again an important question nowadays. Actually, tenalteplase doesn't have FDA approval, and tenalteplase there is a lot of business things going behind that. Why it is not got approval and all? I will not tell that. That is not for academic. So, but tenalteplase has come up in Canadian guidelines. Tenalteplase has come up in many other guidelines. Even in American Society, they are pushing tenalteplase. They're giving tenalteplase for large vessel stroke taking for intervention. You can give tenalteplase because you can save the time. So practically tenalteplase is easy, but evidence is more for altiplase. So if what we follow is altiplase only. If you don't have much window, or if it is a large vessel stroke planning for thrombectomy, we will go with tenalteplase. Otherwise, we will go with altiplase. Antiepileptic in ischemic stroke, there is no indication for antiepileptic in ischemic stroke unless patient has seizures. If the patient comes to you with seizure at onset, that is within 7 days, within the first 7 days or up to 14 days of stroke, classically 7 days, the patient had seizures. That means that it is a symptomatic seizure secondary to stroke. There you have to give antiplatelet for a short duration. I mean, antiepileptic for a short duration, maybe for 1 month or so, you can then slowly taper and stop it. But if the patient had a seizure 2 weeks after onset of stroke, that means it is a gliotic seizure. That means the gliosis is triggering the seizure. There, it is an epilepsy where you have to continue antiplatelets for minimum period of 2 years. Clear? How much long we have to wait to continue antiplatelet? No, antiplatelet has to be continued lifelong. Yeah, we are planning for more such, not only stroke, we will come with something new. I exactly don't know what, but I want to start it, and it depends upon the participation also. Now the participation is slightly good, so we will continue this. I'm planning to bring forward one or two sessions on stroke only. Then we will discuss some neuroradiology. Then we will discuss about other things. So, which is a preferred anti-epileptic? Anti-epileptic in stroke, basically you need to understand, not just see, studying neurology is not like thinking in one point. You have to think in the totality of the patient. See, the patient comes to you with a stroke and developed a seizure. That means that the patient is having a focal seizure, because a focal pathology is triggering the stroke, triggering the seizure, right? So it's a focal seizure, should be focal seizures. So that focal seizures means that the drug should be the drug which you give for focal epilepsy. You have carbamazepine, you have oxcarbazepine, you have levetiracetam, phospholene or eptoin, all those things, phenytoin, all those things you can give these focal seizures. Just you treat focal seizures, go in the same way. And like phenobarbital, all those drugs can cause some cognitive slowing and all, but those drugs are not used nowadays. So nowadays, most commonly used is levetiracetam. Levetiracetam only provides they can trigger depression. So such patients I used to shoot either brivaracetam or lacosamide or lamotrigine or even I will use oxcarbazepine. Message to Marrow Facebook page. They will notify me because I'm not that regularly checking at the Facebook. Sometimes many of you might send me messages. I will sometimes I've seen some messages maybe after 6 months or 7 months. Because you can directly message to Marrow. That will be better because he will forward me at least. We will wind up the session. We will meet soon with much more cases. I also am very happy that we all are meeting together, and you can also bring some cases. I may not be answer the cases right and there only because I also want to refer. I want to also look on. Nobody is picture perfect. We all learn together. Okay, thank you so much.